publication on the prognostic significance of PD-L1 expression as a potential predictor of survival in gastric cancer. Stomach cancer is an urgent problem today, in rank 6 of prevalence in the world, and second on mortality, second only to lung cancer or the later indication. For the treatment of gastric cancer, surgical methods is used in combination with neoadjuvant and adjuvant chemotherapy, but the survival rate of patients remains low. In almost all patients in the late stage, progressive disease are observed against of the background of treatment. The search for few therapeutic possibilities is based on the study of the complex biology of malignant tumors, understanding the genetic and immunological mechanism of their development and progression. The ability of some tumors of express PD-1, ligands of the surface an independent mechanism of tumors, immune resistance observed even with the development of an effective T-cell response to tumor antigen. Most epithelial tumors are characterized by acute immune resistance, adaptive immune resistance, in which PD-L1 expression is a cytologist's adaptation mechanism. Nivolumab, human monoclonal antibodies, became the first anti-PD-1 agent to demonstrate clinical efficacy for the treatment of certain cancers, including melanoma, renal cell carcinoma, and non-small cell lung cancer, in a study completed in 2012 by Copeland et al. In 2014, nivolumab was approved by the FDA for the treatment of advanced stages of melanoma. Today, the development of diagnostic systems for determining the status of PD-1 tumors is carried out mainly in cooperation with manufacturers of certain drugs, and testing of the sensitivity is carried out within the framework of clinical trials of the corresponding drug. Clinical research data indicate an ambiguous prognostic value of PD-L1 due to the high heterogeneity of expression. The criteria of positive was a complete circular of patient staining of the cell membrane with intensity from week 1 plus to proposed 3 plus. Several methods for assessing the PD-1 status of a tumor and their correlation with the effectiveness of treatment were investigated. The percentage of tumor cells on 1, shown staining of any intensity, proportion score 1, PS1, and 2, percentage of tumor cells showing moderate or profound staining PS2. And 3, the percentage of tumor cells shown only profound staining PS3 or 4. The histochemical index, histochemical score, H-score, HS, on the sum of PS1, PS2, or PS3. The role of immune cell infiltration of the stroma tumor is also important. A number of studies have also included formula of calculation positive cells in the microenvironment to determine the one status. Considering that both CPS and NITs mathematically represent fighting with the same determinator, the two indicators were combined into a single combination of positive score CPS. CPS is the ratio of the number of PD-1 expression cells, both tumor and immune, to the total number of tumor cells. The multiplier of 100 was added in order to avoid fractional value on the indicator. This slide provides brief information of the criteria and the use of diagnostic range to count for the positivity for the PD-L1 status. In the study by Yamashita et al., a positive response to therapy was observed, including among patients with a negative PD-L1 status. Once again, the questions of the ambiguity of testing in its current form and protocols was raised. In clinical studies of the effectiveness of nivolumab among patients with gastric cancer, there was also non-relationship between treatment success and PD-L1 status determined by the TPS method, PD-L1 HC 28 and 8 funds DACA. There were so many things in my research. To study the relationships of PD-L1 status in the use of SP 142 and SP 263 clones in gastric cancer with its clinical and morphological parameters. To evaluate the prognostic significations of PD-L1 expressions of both clones in patients who did no reserved adjuvant therapy with immune checkpoint inhibitors. Relations with PD-L1 performed using the Ventana benchmark ultra device, Roche Ventana in USA, according to the protocols recommended by the manufacturers of primary antibody. No later than 24 hours after the manufacture of paraffin infection. Concealer and flesh-sample tissue were used as controls for immunohistochemical reactions. 127 cases were stained with antibodies to PD-L1 SP 263 and 126 cases with antibodies to PD-L1 clone SP 142. The study of the drugs studied antibodies stained with the immunohistochemical markers PD-L1 began with a review at a low magnification and 5. Lens compliant a general morphological picture. After that, the areas of interest with a larger magnification of 20. We carefully examined to determine the staining substrate, and then, when view again low magnification, the desired indicator was determined. Determinations of PD-L1 status by antibody PD-L1 with clone 263 and CPS methods. In this study, the following parameters were evaluated: the percentage of staining tumor cells (TPS), the proportions of staining immune cells of the combined positive scores. This is CPS. The assessment was performed under a light microscope and the staining image. For a reliable assessment of the proportions of positivity staining tumor of immune cells, all studied cells with full of membrane stains of intensity were occurred for. The assessment was carried out not both hotspots, but the average value was output for the entire volume of the tissue under study. Examples of varying degrees of intensity of staining of clones of the immunohistochemical marker PD-L1 are given for illustrated example. The results are estimated from 0 to 4 points respectively. In this slide, we show how we counted positive cases and what criteria were excluded. Explains of positive reactions with clones PD-L1 SP 142 and SP 263 at an increase of 20 respectively are shown in this picture. The following slides present the number of cases counted with the CPS and TPS methods on both clones. A high number of positive cases were determined to use clone SP263, and this clone has a greater sensitivity to tumor cells than to immune cells of the microenvironment. The difference of the stain of the same preparations in two different clones is shown on these pictures. For variable treatment and demonstrations of visibility, the most representative field of view of the same slide staining with different antibodies were taken into account. The largest proportions of PD-L1 positive cases for both clones is significantly associated with tumors of the tubular type according to the World Health Organization classification, and intermediate types according to Lauren, and types to according to Borman. And in the absence of signal cells, when patients' survival was analyzed, the survival of PD-L1 positive tumors group was higher than in the PD-L1 negative tumors group. Within the framework of the study, frequency of detected to positive PDL status by the TPS methods was clearly demonstrated, which is not allowed for patients who may have a positive response to immunotherapy, not to receive proper treatment. It was determined that to use clone of SP263 and SP242 clones leads to different results in the analysis of the alternative date, regardless of the assessment methodology used. In the current study, it was clearly demonstrated that the studied clones have different degrees of staining intensity in the case of positive results, as well as with negative results when using one of the clones, but other of them could have a positive staining. So there is a difference in which worse considering the scheme of the proposed immunotherapy of the particular patients. Each particular case of the disease should have its own individual treatment regimen, the selection of immunotherapy drugs. And thank you for your attention. In conclusions, I would like to say that our research continues, and this may serve a reason for our meeting in the next year. Thank you so much.
Yeah.
In a PhD program at the Department of Obstetrics and Gynecology at the Odessa National Medical University. I would like to present you a report on the topic changes of platinum-resistant biochemical markers under the influence of hyperthermia during the HIPEC procedure in recurrent ovarian cancer. The main topic of my research is ovarian cancer and the development of drug resistance, which significantly complicates the treatment and worsens treatment outcomes, overall survival and progression-free survival. So a few words about ovarian cancer. It is one of the most common malignant tumors of the reproductive organs and has the highest mortality rate among all gynecological malignancies. At diagnosis, approximately 70% present with advanced disease, and most are resistant to platinum-based chemotherapy, resulting in low 5-year survival rates. The initial response to platinum-based chemotherapy is as high as 80%, but in most advanced patients, final relapse and deaths are caused by acquiring drug resistance. The mechanisms of platinum resistance are multifactorial and comprise genetic and epigenetic alterations, as well as immune and environmental factors, frequently involving more than one factor of resistance. DNA is the main target of platinum-based anti-cancer drugs, and the cell's ability to recognize and repair drug-induced DNA damage can influence its sensitivity or resistance to platinum chemotherapy. So the primary mechanism through which platinum chemotherapy exerts its cytotoxic effects is the formation of DNA monoducts that evolve through covalent binding to DNA crosslinks that can occur either on the same DNA strand or the opposite strands, generating interstrand crosslinks that block DNA synthesis and transcription if they are not repaired. The DNA damage response mechanism is activated to the presence of DNA lesion, and DNA damage response consists of several signaling pathways responsible for enforcing cell cycle arrest, and depending on the severity of DNA damage, either DNA repair or the activation of apoptosis for cells presenting with unrepairable DNA lesions. 6 major DNA repair pathways have been described: mismatch repair, base excision repair, nucleotide excision repair, homologous recombination, non-homologous unjoining, and Fanconi anemia. So ERCC1 is a protein critical in the nucleotide excision repair pathway. The key role of nucleotide excision repair is removing platinum-induced DNA lesions. Has been suggested by extreme sensitivity of cells lacking functional excision repair cross complementation group 1 or ERCC1. It was shown that neoadjuvant chemotherapy treated epithelial ovarian cancer tissues shows a 2-fold increase in ERCC1 expression compared to chemo-native epithelial ovarian cancer tissues. This is why ERCC1 has been the most investigated potential biomarker of therapeutic response at the genomic level analysis of single nucleotide polymorphisms, at the transcriptional level, reverse transcriptase PCR, and at the protein level immunohistochemistry in different tumor types in retrospective and prospective studies. However, the results have been contrasting with some studies. Mismatch repair deficiency and Bethesda panel microsatellite instability are increasingly analyzed to identify a tumor that might benefit from immune checkpoint inhibitors and may have additional way to overcome platinum drug toxicity, but some tumor heterogeneity is a potential obstacle for such analysis. In ovarian cancer, data on intratumoral heterogeneity of MMR deficiency or MSI are lacking. From 7 to 10% of ovarian cancers are mismatch repair deficiency by immunohistochemistry or MSI high. Retrospectively, also studies where both techniques are used do not suggest that one technique is superior. It is clinically significant as this cancer would potentially be amenable to immunotherapy, a treatment that has been shown to be highly effective in solid cancer with MMR deficiency. So interval debunking surgery is an option for treating patients with advanced ovarian carcinoma. Two randomized trials have shown similar survival rates for primary debulking surgery and interval debulking surgery. And neoadjuvant chemotherapy followed by interval debulking surgery could improve the optimal debulking rate and decrease the postoperative adverse reactions for the current studies. But whether it could improve overall survival and progression-free survival compared with the primary debulking surgery followed by chemotherapy in patients with ovarian carcinoma figure stages 3C and 4 were still needed to be verified by conducting more randomized controlled trials. One of the concerns with interval debulking surgery is a potentially higher risk of inducing platinum resistance when treating patients with greater disease volume. So hyperthermia, one more promising treatment agent, delays the repair of DNA damage caused by cisplatin or doxorubicin, acting upstream of different repair pathways to block histone poly-ADF ribosylation, a known effect of chemotherapy. Furthermore, hyperthermia blocks this histone modification as effectively as pharmacological inhibitors of PARP, producing comparable delay in DNA repair, induction of double-strand breaks, and cell cytotoxicity after chemotherapy. Mild hypothermia, 41 to 42.5 degrees by Celsius, induces degradation of BRCA2 and inhibits homologous recombination. It is demonstrated that hypothermia can be used to sensitize initially homologous recombination proficient tumor cells to PARP inhibitors, and that this effect can be enhanced by heat shock protein inhibition. Here we comes on to the hypothermic intraperitoneal chemoperfusion, or HIPEC, which has been actively studied in recent years as a possible addition to therapy for advanced stages of epithelial and ovarian cancer locally spread by the peritoneal cavity. This slide shows large randomized clinical trials regarding SETI reduction and HIPEC. We are most interested in the last study called M06 OVH HIPEC, which examines the combination of interval SETI reduction and HIPEC, the only one to this date that has reliably proven its effectiveness, on the basis of which recommendations were made to the NCCN protocol, which you also see on the slide. What was the design of the study I conducted? It was retrospective. We collected the data of 16 patients with the stage 3C epithelial and ovarian cancer treated in 2013-2014 years in the University Clinic of Odessa National Medical University. All of them had high primary levels of ERCC1 expression, over 50% of cells. They have obtained CC1 suboptimal CT reduction surgery with HIPEC, plus second lung surgery with CC01 CT reduction, so complete or optimal, or realotomy during to surgical complication, for example, anastomosis leakage and early adhesive intestinal obstruction, etc., with the biopsy of residual disease in 2-4 weeks interval. Those interventions, as you understand, have been performed before we have got the trials and treatment protocols forcing us to only perform HIPEC procedure with complete CT reduction. But we can get some interesting data from this retrospective site. Immunohistochemical investigation of ERCC1 expression were performed for histology obtained from pre- and post-HIPEC metastatic tumor tissue on the first and second surgical intervention. Then we choose 9 of these patients with pre-HIPEC immunohistochemical expression of MLH1 over 5% and compare it with the post-HIPEC results. On this slide presents paired immunohistochemical micrograms of ERCC1 expression of tumors of 16 patients during the first surgery with HIPEC and after repeated surgery with a 10-fold magnification obtained using monoclonal anti-human ERCC1 clone 4F9 antibody. The median pre-HIPEC expression of ERCC1 was 57.56%. Median post-HIPEC expression of ERCC1 was 5%. Students' t-test for matched samples was used to compare the results. Empirical t-value was 22.3, critical for p below 5% was 2.13, for p below 1% was 2.95, and they obtained reduction of ERCC1 expression in cells of metastatic nodes of epithelial ovarian cancer is statistically reliable. Next slide shows pairwise immunohistochemical micrograms of MLH1 expression on tumors of 9 patients during the first surgery with HIPEC and after repeated surgery with 10-fold magnification obtained using monoclonal MLH1 antibody clone ES05. Median pre-HIPEC expression of MLH1 was 9.13%. Median post-HIPEC expression of MLH1 was 0%. Students' t-test for matched samples was used to compare the results, and empirical t-value was 5.3, critical for p below 5%, 2.31, for p below 1%, 2.33, and the obtained reduction of MLH1 expression in cells of metastatic nodes of epithelial ovarian cancer is statistically reliable too. What we can conclude from this data? The DNA repair pathways like mismatch repair, base excision repair, nucleotide excision repair, homologous recombination, non-homologous enjoining, and Fanconi anemia are one of the most important factors of platinum drug-resistant formation. Hyperthermia during HIPEC procedure leads to a decrease of efficiency of DNA repair pathways by reducing the expression of ERCC1 and MMR proteins. These changes may determine the proved effectiveness of HIPEC procedure with CT reduction after neoadjuvant chemotherapy, which may lead to secondary platinum drugs resistant formation by overcoming such platinum resistance. Thanks for your attention.
Thank you, Doctor. Now the forum is open for discussion.
To give a lecture to the conference. Today I will talk about risk organs, delineating organs at risk in radiotherapy. Next slide, please. Organs at risk are healthy anatomical structures located in close proximity to target volumes. When creating the radiation therapy plan, special attention should be paid to organs sensitive to ionization radiation, because radiation can cause the pathological changes in healthy tissues with irreversible damage. Those volume limits are placed on organs at risk according to international guidelines. ICRO, International Commission of Radiation Units and Measurements, developed and published internationally accepted recommendations on quantities and units related to radiation, terminology, measurement procedures, and reference data for the safe and effective application to ionization radiation, to medical diagnosis and therapy, radiation science and technology, and protection of individuals and population from radiation. Next. The goal of radiotherapy, one of the methods of treatment for oncological patients, is to control the growth of tumor, but at the same time one should be careful to possible complication caused by radiation in the surrounding healthy tissues. It's necessary to deliver the prescribed absorbed dose to the area of interest. Will the simulations deliver dose to the surrounding healthy tissues, especially to organs sensitive to ionization radiations, should be as small as possible. When creating the radiation therapy plan, special attention should be paid to organs sensitive to ionization radiation, organs at risk, because it can cause pathological changes in healthy tissues with irreversible damage. Next. Radiotherapy is complex process that involves a large number of steps. It consists of establishing a diagnosis, obtaining image information about the patient anatomy, CT, MRI, PET, delineation the volume of interest, calculating and optimizing the absorbed dose distribution, dosimetric evaluation on the absorbed dose distribution, and checking patient position and performing radiation therapy on the linear electronic accelerator. Next, please. On transfer section of anatomical area of interest obtained using the CT simulator are determined target volumes of radiation prescribed to absorb the dose required to achieve tumor control. First of all outlines macroscopical visible tumor mass, GTV is gross tumor volume. After the volume containing GTV and subclinical, it's outlined in microscopic spread of disease. CTV, it's clinical target volume. PTV is planning target volume, is used to create the dose distribution itself. It is a geometric volume created around the CTV with extra margins to security, no CTV coverage. The margin around CTV is added due to patient movement during breathing psychological moment of organs and unnecessary in everyday position. The patient PRV is planning organ at risk volume. Estimates should have been reported as methods for sparing organs at risk during radiation therapy, especially for hypofractionated or those escalated protocols. Next. In picture one, we have a schematic representation of outlined the basic targets volumes, is PTV, CTV, GTV, OR, and PRE. Next. Organs at risk are healthy anatomical structures located in close proximity to target volume. The radiotherapy and oncology specialist outlines the target volume and define the prescribed dose to the target volume and knows the limits for each of the organs in the anatomical area of interest. delineation of organs at risk can be performed by radiological technologists who is additionally educated in this area. Next. We will list the all important organs at risk. It's optic nerve, bladder, colon, brachial plexus, heart, eyeball, femoral head, duodenum, thyroid, small intestine, esophagus, parotid, rectum, kidney, chiasma, brainstem, spinal cord, liver, lowerjaw, lungs, lenses, uterus, oral cavity, seed, and cochlea. Next. Delineation of organs at risk will shown in 4 anatomical regions is head and neck, chest, abdomen, and pelvis. In the indicated anatomical region, those organs at risk that are outlined in the majority of clinical cases are shown. Next. For the purposes of radiotherapy of the central nervous system, the area from the top of the skull to the edge of the third cervical vertebra is scanned with computer tomography, so that as a result we get transverse section 2 or 3 millimeter thick organs at risk that need to be outlined when irradiation irritating the CNS area and paying attention to the dose that will be delivered to them. It's our eyeball, optic chiasma, cochlea, lens, optic nerve, spinal cord, and brainstem. Next slide. For the purposes of radiotherapy of the head and neck area, the area from the top of the skull of the fifth to the fifth thoracic vertebra is scanned on CT so that we obtain transverse section 2 or 3 millimeters thick. Organs at risk for this area is parotid gland, lower jaw, manual plexus, larynx, oral cavity, thyroid gland, spinal cord, brainstem. Next slide, please. In picture 2, we have a central nervous system, and we have organs at risk: eyeball, optic chiasm, lens, optic nerve, and brainstem. And the picture 3 of head and neck, we have delineating oral cavity, parotid gland, lower jaw, spinal cord in this slide of CT. In the case of tumor located in chest, tomographic section of this area from the cricoid cartilage of the larynx to the second lumbar vertebra are sampled with CT in layers to 3 millimeters thick. Organs at risk that need to be outlined is spinal cord, esophagus, heart, left lung, right lung. Next. For the breast radiation, tomographic cross-section of the area from the larynx to the upper abdomen with a cross-section thickness of 3 millimeters are taken. We mark the breast with non-transparent marks before CT centering for easier and more precise in delineation of breast tissue of CT section. Organs at risk for breast radiation are the heart, the right lung, left lung, and the other breast. Next. In picture 4, we have a thorax, and delineation organs is the spinal cord, esophagus, heart, left lung, right lung, and in picture 5 we have a breast. In this slide of CT, we have a delineation of heart, the right lung, left lung, and the second breast. In the abdominal region, CT scans are taken of the area from the sternum to the proximal part of the femur in layers 3 to 5 millimeters thick. The risk organs that need to be unlighted are the spinal cord, liver, large intestine, left kidney, right kidney, duodenum, and small intestine. In picture 6, we have in CT scan we have a delineation of spinal cord, left kidney, right kidney, large intestine, and small intestine. And last, for the purposes of radiotherapy of pelvic area, tomographic section with a thickness of 3 millimeters from the third lumbar vertebra to the proximal part of the femur are sampled with CT device. Delineation of organs risk in the pelvic area differs depending on the gender of the patient. In female patients, in a female patient, the urinary bladder, no, just a second, thickness. Delineation of organs risk in the pelvic area difference depending on gender of the patient. In female patient, the urinary bladder, the end of part of large intestine, the head of the right femur, and the head of the left femur, the right ovary and the left ovary. In the pelvis of male patient, the same but more the testicles. In this picture 7, we have in this CT scan delineation of urinary bladder, head of the right femur, head of the left femur, terminal part of the large intestine. And during the planning of radiotherapy, special attention should be given to organs at risk. Radiation can cause pathological changes and irreversible damage to healthy tissues. The tolerance to the received absorbed dose varies depending on the radiosensitivity and an anatomical structure. Successful implementation of radiotherapy requires the team consisting of radiation oncologists, medical physicists, and radiation technologists. Accurate delineation of target volumes and organs at risk is a crucial factor in achieving successful outcomes in radiotherapy treatments. Thank you for your attention. If you have any question, this is my mail. And that's all.
Thank you, Mr. Ivan. Now the forum is open for discussion.
You're welcome.
This was a cross-section study, was conducted to evaluate 104 patients who underwent surgery for colorectal cancer, adenocarcinoma, between 2007 and 2014. The study included patients aged between 18 and 90 years old and at any clinical stage of cancer. As control sample, you use the surgical margin sample of 22 patients with colorectal cancer, take from 10 centimeters of tumor area. The study variables were annexin A1 expression, which was classified as positive or negative according to results, immunohistochemical results, sex, age, group under 40 years old and over 40 years old. Tumor location classified as colon or rectal tumors. Histological types of tumor, which was either tubular or mucinous, and tumor differentiation. We studied too blood carcinoembryogenic antigen, the blood's level, and were defined as abnormal over level 5. And the expression of mismatch repair, MLH1, MSH2, and MSH6 protein, which was characterized as either positive or negative according to results. An additional variable called Mutations was considered positive in patients that show MSH2 and MSH6 positive expression. The aim was to find an association between tumor marker. Therefore, the association measure refer to prevalence ratio, which expressed the probability of annexin A1 and the other variables being present. Study designs a cross-section study. Participants 104 adults, 61 male, and 43 family. Mean age were 56 years old, and the tumor were distributed in two anatomical size, colon with 52 patients and rectum with 52 patients. Annexin A1 expression was positive and negative, positive in 31 patients and negative in 73 patients. Annexin A1 expression was higher in tumor tissue than in normal colorectal tissue. P-value 0.0001. The tumor were distributed equally between two anatomical size, 22 tumors located in the colon and 52 in the rectum. In terms of histological type, the most tumor, 83%, were tubular adenocarcinoma, and 16% were mucinous adenocarcinoma, and just one case was a side right cell carcinoma. The distribution according to the clinical stage was 1% stage 0, 6% stage 1, 23% stage 2, 26% stage 3, and 32% stage 4. Annexin expression was positive in 31 patients, 29%, and negative in 73 patients, 70%. Annexin A1 expression in tumor tissue was higher than in normal margin colorectal tissue. The value P is significant. When we analyze the annexin A1 expression in colon and rectal tumor, no differences were observed. The annexin A1 expression showed the absence of association with clinical stage and differentiation degree. However, in rectal tumor, a high incidence of annexin A1 positive expression was observed in adenocarcinomas mucinous tumor when compared to tubular. Value P 0.05. Then we analyze the association between annexin A1 expression and the carcinoembryonic antigen levels. Our results demonstrate a significant association with those molecular in colorectal cancer patients. P-value 0.004. Similar results we observed when we analyzed annexin A1 and carcinogenic antigen in colon tumors only, with p-value 0.033, but no association when observed in rectal tumor only, p-value 0.132. Although this association was performed in only 8 patients, consider the confidence interval of 90%, this Amoster number was enough to perform the statistical analysis. Our data demonstrated no association of annexin A1 and mismatch protein repair in colorectal cancer. In the present study, we assessed the association between the expression of annexin A1 and the carcinogenic antigen and the mismatch repair, MLH1, MSH2, and MSH6. Annexin 1 expression was significantly higher in colorectal cancer in our patients in the normal margin colorectal TC. However, there was no association between annexin A1 expression in the clinical stage, histological type, and the colorectal cancer tumor differentiation grade. These results are in line with the literature. There were no statistical difference between the annexin A1 expression in colon and the rectal tumor. That might indicate the importance of this protein in the tumor biology in both anatomical sites. However, the analysis of annexin A1 expression in patients with rectal cancer showed that most patients with mucinosis, 66%, were positive for annexin A1. These results to be further evaluated due to the small number of patients with mucinous adenocarcinoma in our study. Then, when investigate the positive annexin A1 expression with CA level, we found a positive association between increased level of these molecules in colorectal cancer. This association is also observed in colon tumor, but not in rectal tumor. Our data might indicate the annexin A1 has a participation in the biology mechanism that would ultimately
I don't have any financial relationships. Unrepaired DNA damage can lead to genetic mutations resulting in malignant transformation. There are multiple pathways controlled by multiple genes involved in DNA damage repair. This is well known. The polypolymerase family of proteins controls response to single-strand DNA breaks by detecting these damaged sites and recruiting the proper factors for repair. So this is a cartoon showing mechanism of action of PARP inhibitor. You can see this is a double-strand DNA. One of the strands was broken, and the PARP protein can recognize this broken single-strand DNA and recruit repair factor base excision repair elements to repair this broken single-strand DNA, and the cells can survive. Blocking this pathway forces cell to utilize complementary mechanisms to repair DNA damage. If there's a PARP inhibitor present in the environment, it combined with PARP protein and form a complex, and the PARP protein cannot recognize the broken single-strand DNA. So the single strand broken DNA converted to double strand broken DNA, the cells will die. If the cells have other repair system, HR proficient, other repair mechanisms can still repair the broken DNA and the cells survive. If the cells are HR deficient, there are not enough complementary mechanism to repair the broken DNA, the cells will die. It's called apoptosis. So proteins encoded by BRCA1 and BRCA2 genes are critical for homologous recombination repair, HR. And except BRCAs, there are other HR genes includes but not limited to those genes. So effectiveness of PARP inhibitors. The effectiveness of PARP inhibitor exists in patients with ovarian cancer, breast cancer, prostate cancer, and pancreatic cancer. So this is FDA-approved trials in breast cancer. This is the first trial that FDA approved. In 2018, FDA approved olaparib for the treatment of patients with deleterious or suspected deleterious germline BRCA mutations, germline BRCA mutations, HER2 negative metastatic breast cancer, who have been treated with chemotherapy either in the new adjuvant or metastatic settings. So the breast companion diagnostic test approved by FDA was BRCA analysis CDX test. And the biomarker for it is germline BRCA1 or 2 mutations. This is the second clinical trial that FDA approved for a PARP inhibitor in breast cancer patients. In 2018, FDA approved talazoparib for patients with deleterious or suspected deleterious germline BRCA mutations, HER2 negative, locally advanced or metastatic breast cancer. The same companion diagnostic test approved by FDA, BRCA analysis CDX2 test, the biomarker was germline BRCA1 or 2 mutations. So is there any other avenues for PARP inhibitor therapy for breast cancer? So this is our investigation recently published in Cancers. Mutations, the same title. So what did we do? We identified 63 patients diagnosed and treated as invasive breast cancer, carcinoma, from 2019 to 22 in our institution. And we collected clinical characters, including age, clinical stage, history of surgery, systemic therapy, and clinical treatment response. Also, we collected pathologic characters, including histologic type, histologic grade, pathologic stage, and receptor status, ER/PR2. And we collected NGS data. The NGS was performed in formalin fixed paraffin embedded tumor blocks. And the blocks from 34 patients underwent whole exome sequencing with enrichment of around 700 clinical relevant genes and whole transcriptome sequencing with genomic signatures, including MSI, microsatellite instability, tumor mutational burden, and HRD score, LOH. 29 patients, the tumor blocks from 29 patients underwent FDA-approved comprehensive genomic profiling, targeting 324 key cancer-related genes, as well as genomic signatures, SMI, MSI, and tumor mutational burden. We only included pathogenic and likely pathogenic alterations considered as carrying a pathogenic mutations. gene alterations with a variant of uncertain significance were excluded in this study. We divided our cohort into 4 groups based on BRCA status: BRCA1 mutated group, BRCA2 mutated group, BRCA wild type, and HRR gene mutated group, both BRCA1 and HR wild type group. We used 16% cutoff to define LOH high or LOH low. We evaluated clinical treatment effect based on radiological studies before and after PARP inhibitor therapy, 3 months or longer. And the treatment effect was graded as complete response, defined by the disappearance of all the lesions. Partial response, defined as more than 50% decrease in tumor size. Stable disease, defined as the tumor falling between a less than 50% decrease and a more than 25% increase in size. Progressive disease was defined as more than 25% increase in tumor in size. So 4 tiers. And we defined HR genes based on Foundation 1 recommendation. You can see those are the genes we consider as HR gene in this study. And in our cohort, we identified 13 HR genes among the recommendation listed in this red squares. The basic clinical pathological features in this cohort, among 63 patients, 95% were high clinical stage 3 or 4. 42% were high pathologic T stage, T3 or T4. 63% were high N stage, positive N stage, N1 through 3. And 60% were high non-hem histology grade 3. More pathologic features. 38% of the patients were ER negative. 49% were PR negative. 33% were triple negative breast cancer. And among the 63 patients, 6 of them indeed received PARP inhibitor therapy in clinical trial settings. So this picture shows the distribution of HR gene mutations in our cohort. You can see among 63 patients, 5%, 3 patients had BRCA1 mutation. 1 patient, 1% had BRCA2 mutation. 12 patients had BRCA wild type other HR gene mutations, 19%. And this picture shows the other HR gene mutation distribution among the 12 patients. These 12 patients here. 1 patient had BRIP1, 1 patient had multiple gene mutations, 1 CHEK1, 1 CHEK2, 1 EMS1, 1 FANCA, 1 FANCA D2, 1 MRE11. 2 patients had PALB2. This gene is very important. I will mention it later. And 1 had RAD50. And we correlated HR gene mutations and pathological features. We identified that HR gene mutations is positively correlated with high N stage and N3 stage. Also, we identified HRG mutations is positively correlated with HER2 negativity. So from this data, we can see HRG mutation is associated with unfavorable pathologic features. Also, we correlated a LOH score with pathologic features. We identified LOH high is possibly associated with T4 stage. LH high is possibly associated with N3 stage. LH high is possibly associated with Nottingham grade 3, high Nottingham grade. LH high is possibly associated with triple negativity. LH high is possibly associated with ER negativity. Oops. So from this data, we identified that LH score is associated with unfavorable pathologic features in breast cancer. And then we have 33 patients had available LH score for analysis. This picture shows distribution of HRG mutations in carcinomas with a available LH score among the 33 patients. You can see 82% were HR wild type, and unfortunately, none of the patients had BRCA mutation, and 6 patients had other HRG mutations. And then we use 16% as a cutoff to define LH high, LH low. The interesting finding is among the LH high patients, there are 9 patients, only 1 patient had HRG mutation, Bangkok mutation, and among the LH low group, there are 5 patients had HR mutations. So this is very interesting. You would expect LH high would recognize more HRG mutations, but in our study, LH low score identified more HRG mutations than LH high. And as I mentioned before, there are 6 patients received PARP inhibitor treatment in a clinical trial setting. The interesting thing is 3 of the patients had BRCA1 mutation. 1 patient had disease-free. 1 patient had stable disease. 1 patient had progressive disease. So not all the patients had a BRCA mutation responded to the treatment. There's 1 patient was BRCA negative, but PALB2 mutated. And this patient did respond to treatment, showed partial response. And there's 2 patients had BRCA1 and BRCA2 VUS. And they received a PARP inhibitor treatment. 1 discontinued because of the side effect. 1 had progressive disease. So this patient failed to show response to PARP inhibitor with BRCA1 VUS. I'm showing representative cases. This is 1 patient with that PALB2 mutation. This is a morphology of the breast cancer, high grade. This is a liver metastasis. You can see the identical morphology. And this figure C showing a 8.2 millimeter retroperitoneal lesion before PARP inhibitor treatment. And after 7-month treatment, this retroperitoneal lesion disappeared. Figure E showing a 27 millimeter liver lesion before PARP inhibitor treatment. And after 7-month treatment, this lesion shrinked a lot. I think it's going down to a few millimeters. So this is a representative case that the tumor was BRCA negative, but carrying a PALB2 mutation, and this patient indeed responded to PARP inhibitor treatment. This is another representative case. This patient had BRCA1 and FANCA mutations in the tumor. Figure A shows the breast lesion, Nottingham grade 3 tumor, breast cancer invasive ductal, and figure B shows the orbital lesion, metastasis. You can see these two tumors have identical morphology. And figure C shows the liver lesion before PARP inhibitor treatment. The lesion was 25 millimeter. And after 4-month treatment, you can see the lesion increased in size to 36 millimeter. And figure E showing the bone signal. You can see scattered bone lesions here and here before treatment. After 4-month treatment, you can see the bone signal increased intensity and areas. So there's more bone metastasis after treatment. This is a representative case that the patient had tumor with BRCA mutation, however, did not respond to PARP inhibitor treatment. We propose that this patient did not respond to treatment probably because of the FANCA mutation. It has been reported that FANCA mutation, the tumor carrying FANCA mutation had worse prognosis. So probably this is why. This is another representative case that the patient had tumor carrying BRCA VUS. Figure A shows the breast the tumor, high-grade invasive ductal carcinoma. Figure B showing the neck soft tissue metastasis. You can see the two tumors show identical morphology. And figure C shows the bone scan before treatment. You can see here are the signals before treatment. And after treatment, you can see there's more increased bone signals. And so this patient did not respond to treatment. So conclusions. Pathogenic mutations in HR genes were presented in 25% of 63 breast cancers in our cohort and were associated with triple-negative breast cancer. A LH high score showed a positive association with high histological grade and triple-negative breast cancer, and LH high score only identified a subset of breast cancer with non-BRCA gene mutations. Of 63 patients, 19 carried a non-BRCA HR gene mutation in their tumors, and BRCA inhibitor was effective against some of these tumors, not all. So we hypothesize that next generation sequencing with full HRD gene analysis should be considered when PARP inhibitor treatment is contemplated in advanced breast cancer. However, this hypothesis requires further confirmation in clinical trials of PARP inhibitor with full genetic status characterization. Thank you. Questions, please.